Hello students, the topic of this lecture is acute purulent diseases of the lungs. The following diseases of lungs are distinguished: abscess pneumonia, acute and gangrenous abscesses, focal and extensive lung gangrene. Abscess pneumonia is a multiple destructive foci 3–5 mm in size within 1–2 segments of lungs, which is not disposed to progression. The destruction is accompanied by expressed perifocal infiltrate of a pulmonary tissue. Lung abscess is a purulent or ichorous destruction of pulmonary tissue within one segment with formation of one or several cavities filled by pus and detached from adjacent parenchyma by a pyogenic capsula and expressed perifocal infiltration of surrounding pulmonary tissue. Gangrenous abscess is a purulent ichorous necrosis of a pulmonary tissue within 2–3 segments detached from adjacent pulmonary parenchyma with the liability of sequesters formation. Depending on reactivity of the organism, it can transform into purulent abscess after the lysis of sequesters or gangrene. Lung gangrene is a diffuse purulent ichorous necrosis of the tissue without the tendency to defined demarcation, with prompt dynamics of spreading of necrotic zone and destruction of the parenchyma. It is characterized by a grave intoxication, liability to a pleural complication, and pulmonary bleeding. There is limited and widespread lung gangrene. What are the predominant factors of suppurative lung process? The predominant factors are disturbances of bronchial patency with the development of atelectasis, infectious inflammatory process in the pulmonary tissue, regional disturbances of blood supply with a further necrosis of areas of pulmonary parenchyma. A lot of classification of acute suppurative disease of lung. According to the pathogenesis, divide the post-pneumonic, aspirative, obturative, post-traumatic, hematogenous or septic, lymphogenous, and thromboembolic. According to the character of purulent process, there are single purulent abscess, multiple purulent abscesses, bilateral purulent abscesses, gangrenous abscesses, single, multi, uni, and bilateral, limited gangrene, and widespread gangrene, according to the localization with the indication of affected segment or lobe. According to the stage, there are 3 stages of this disease. At first stage, the necrotic pneumonia. The second stage, destruction and rejection. Third stage, cleaning and cicatrization. According to the term of existence, acute and chronic, and according to the complications, pulmonary bleeding, pneumothorax, pleural empyema, sepsis, and bronchogenic dissemination. What peculiarities of the clinical manifestation of acute purulent destruction of lungs? At first, the size of the focus, character of destruction, reactivity of the organism, stage of the disease, features of the drainage of purulent cavities, and the presence complication. What causes of lung abscess? The reasons of the development of lung abscess can be divided into 2 groups, primary and secondary. The causes of primary abscess are the following disease and syndrome. At first, necrotizing pneumonia, which is caused a number of microorganisms. Staphylococcus aureus, Klebsiella, and many others. Second, aspiration pneumonia, which that occurs after anesthesia, stroke, drugs, and alcohol. C, esophageal disease group. And D, immunodeficiency, including cancer and state after chemotherapy, diabetes mellitus, organ transplantation, steroid therapy, malnutrition, which cause the exhaustion of organism. Secondary reason is bronchial obstruction by neoplasm of foreign body, systemic sepsis, which causes systemic pulmonary emboly or seeding of pulmonary infarcts, complication of pulmonary trauma, infection of hematoma or contusion, and contaminated foreign body or penetrating injury. And finally, a direct intention from extraparenchymal infection, which causes pleural empyema and mediastinal hepatic subphrenic abscess. The abscess mainly develop in second and sixth segments of lungs. What clinical picture the acute abscess? It depends on the stage of disease. The first stage of disease before the burst of abscess into bronchus includes the following signs, symptoms: general weakness, headache, malaise, fatigue, suppressed appetite, weight loss, moderate chest pain, dyspnea, subfebrile temperature. The characteristic signs of second stage, after the burst of abscess into bronchus, the state of patient is worst. The chest pain increase and troubling cough appear, dyspnea, the intoxication, fever, chills, cough, and foul-smelling sputum. Patient excrete a large amount of sputum which, when left, is divided into three layers. Inferior layers, resembling a gray mass with detritus and flaps of the pulmonary tissue. Medial, purulent turbid liquid, and upper mucus formicolor. The third stage of acute abscess is the state of recovery, improvement of state of patient, the body temperature falls, the signs of intoxication reduce, and appetite increase. The general condition is gangrenous abscess. In case of gangrenous abscess condition, patient is grave. Expressed purulent intoxication present. Cough with expectoration of great amount, more than 500 milliliters of green foul-smelling sputum, and patient has hectic body temperature. Pulmonary gangrene. The state of patient is critical. The patient is adynamic, exhausted, with edemas of legs. Dyspnea is in rest present. Hemodynamic disturbances. Dirty gray or brown sputum with detritus, threads of blood. Early pleural complication present. Pulmonary bleeding, vital organ dysfunction develop, and loss of consciousness present. There are three of pulmonary hemorrhage are in the three stages. The first degree hemorrhage less than 300 milliliter, divided in single hemoptysis and multiple hemoptysis. Third degree, the hemorrhage from 300 to 700 milliliters, single bleeding or multiple bleeding divided. And the third degree hemorrhage exceeds 700 milliliter, maybe massive bleeding and fulminant lethal bleeding. Chronic abscess develops through more than 6-8 weeks, has a cyclic course. At the stage of remission, the patient is worried, a moderate dyspnea, cough with expectoration of a mucus or mucopurulent discharge. In 6-8 months, notice the clapped fingers and deformation of the chest. What variants of development of purulent disease of lung? At first, favorable course. The second, non-progressive course, transferring of the process in chronic form. Progressing course, encapsulated process, absent of complete obstruction of the draining bronchus under condition of satisfactory resistance of the organism. And complicated course. The diagnostic program of patient with lung abscess is based on complaints and anamnesis, physical findings, X-ray examination of chest in two planes, direct and lateral, CT scan and ultrasound, examination of the sputum, bacteriological and cytological, general blood and urine analysis, biochemical blood analysis, protein and its fraction, immunogram, and fibrobronchoscopy. In this picture, we can see image of lung abscess during X-ray examination. We can see the abscess in the first stage. The acute abscess of right upper lobe of lung, first stage. On this plain film, we can see air fluid level in the is observed within the abscess, indicates the communication with tracheobronchial tree. Is the second stage of disease. In this picture, we can see image of lung abscess during ultrasound examination. The level of liquid shown. And computed tomography reveals the density of mass with a relatively thin wall cavity. Gangrenous abscess. The inline of the cavity is poorly defined. It contains visible sequesters that look as a polymorphous shadow. The adjacent pulmonary tissue is infiltrated. Lung gangrene. Plain film and CT scan. The intensive shadow which occupies a considerable area of lungs with visible cavities that contain sequesters, liquid levels. The shadow outline is irregular but could be well defined if the process is within interlobal sulcus. What tactics in case of acute pulmonary destruction? At first, the adequate antibacterial therapy consists of intravenous introduction of antibiotics of wide spectrum of activities. Use the cauterization of central vein, pulmonary artery, the endotracheal microirrigator nasogastric tube during the bronchoscopy, endoscopic cauterization of the abscess cavity, and intrapleural injection. Second, evacuation of purulent contents of the cavities in natural way by an active sanitization of tracheobronchial tree, transthoratically by means of repeated puncture of external draining of peripheral cavity. Very important is detoxification therapy, intra and extracorporeal immune correction under the control of immunogram, hemostatic correction, anti-inflammatory therapy, and correction of the organ and system dysfunction, prevention of complications, symptomatic therapy. What indication for operative management of in case of acute abscess? At first, failure and of medical therapy. Abscess under tension. The abscess increase in size during appropriate treatment. The abscess larger than 6 cm in diameter and hemoptysis, abscess rupture or pneumothorax. Inability to exclude a cavitating carcinoma. What contraindication to operation? At first, decompensation of the vital systemic function in the terminal stage, bilateral purulent destruction of lungs, and concomitant incurable malignant tumor. Operative management of acute destructive process for abscess includes the external draining, drainage with tube thoracostomy, percutaneous drainage, or surgical cavernectomy for abscess. Lobectomy, segmental, polysegmental resection by lobectomy, combined intervention with the decortication, pleurectomy for bleeding from abscess and pneumothorax, and pneumonectomy, lobectomy by lobectomy for lung gangrene. In the era of many invasive technologies, these interventions are more often performed laparoscopically. The lecture is over. Thank you for your attention.